Continuing with the lecture on pleural effusion. Now, let us see the clinical features of pleural effusion, the symptoms. Pleuritic chest pain, then breathlessness, and depends upon the rate of accumulation of the fluid and the severity of pleural effusion. Then the symptoms associated with the underlying conditions, like if the patient suffering from pneumonia or tuberculosis, then they can have fever, they can have cough, and either the patient could also be asymptomatic as well. Now, talking about the examination findings. First of all, on inspection, you can see the tracheal shift. There is a lot of pleural effusion, and the trachea could be shifted to the opposite direction. And there will be reduction in the chest movement on the affected side. Also, the intercostal space, there could be bulging of intercostal space, especially in case of empyema. We can see the fullness of the chest on that side. On palpation, there will be diminished chest expansion on the side. And also, we can see the increase in the size of the affected hemithorax. This can be documented as increased in spino-scapular distance. Then mediastinum will be shift. We can see this as a shift of apex beat to the opposite side. Then tactile vocal fremitus over the fluid will be reduced or absent. Okay. Then on percussion, very important, stony dull note over the fluid is seen, and the upper level of the dullness is highest laterally in the axilla and lowest anteriorly and posteriorly. And this is the reason we see Alice S-shaped curved in X-ray. We'll see that later on. Then if there is a small left-sided pleural effusion, then it obliterates Traube space on percussion. And also there is one sign, Groko's sign. Groko's sign is seen in moderate or last side pleural effusion. There is a paravertebral triangle of dullness, or it's also known as Groko triangle. It's a triangular area of dullness on percussion, which is seen over the back of the chest on the opposite side of the effusion. And why is it so? This is because of shifting of posterior mediastinum. So the very important thing we need to remember is the stony dull note. Now, talking about the auscultation, the breath sound will be reduced over the fluid. Vocal resonance, like tactile vocal fremitus, it will also be reduced. Then over just above the pleural effusion, we can find bronchial breathing, agophony, and whispering pectori loci. Okay, these are some of the findings on auscultation. Then on investigation on chest X-ray, now which view we should go for? In PA view, erect posture, minimum 200 ml is required to be detectable. AP view, supine position as done in case of bedridden patients, it required even large amount of fluid to be accumulated to detect. And usually it shows ground glass appearance with preserved vascular shadows. It has a different picture. And lateral decubitus view, a very important view. What does lateral decubitus view means? The affected side is down, and it can detect effusion as small as 100 to 150 ml. Okay, then the lateral chest X-ray. Here only 50 ml can lead to blunting of posterior costophrenic angles. Okay, now what are the findings we can see on chest X-ray? The mediastinum shift to the opposite direction, obliteration of costophrenic angle, dense uniform opacity, then Alice S-shaped curved. Alice S-shaped curved, how is it seen on the chest X-ray? If the effusion is here, this is how Alice S-shaped curved. S-shaped effusion. So here the upper border of the opacity is concave upward. Upper border of the opacity is concave upward. And is highest in laterally. It is highest laterally. So this is Alice S-shaped curved. Then in interlobar effusion, we can see the interlobar fissure is wider than normal. And if it is an insisted interlobar fission, as in case of heart failure, then there is a rounded opacity which will resemble like a solitary pulmonary nodule. And now if you give diuretic therapy, it will disappear. So this is known as the phantom tumor. So this is a phantom tumor. Okay. Now ultrasound, it can detect even 5 ml of effusion, and it is usually done to differentiate loculated pleural effusion from pleural tumor or pleural thickening. Now they can detect even septations within the pleural fluid with greater sensitivity than a CT scan. Okay, so why is it used? When we have a loculated pleural effusion, we are confused whether it's a pleural effusion or a tumor or thickening. Then we do the pleural fluid aspiration analysis. Okay, usually 50 ml is aspirated, then it is sent for cytology, staining, gram staining, as well as acid-fast bacilli staining and culture. Okay, and cytology, cells, glucose, protein content, LDH level, all of these things are screened for. Okay, so now we'll continue forth in the next lecture.